Greetings to each of you that is joining us today for the latest CAEP National Grand Rounds. My name is Rafiq Andani, and I am a point-of-care ultrasound enthusiast, an urgent care physician based out of Winnipeg, Manitoba, and I'll also be your moderator for today's National Grand Rounds panel. CAEP has combed the nation from coast to coast and found 4 speakers from across the land that are prepared to present some interesting point-of-care ultrasound cases within the rural and remote clinical environment. Dr. David Bradbury Squires is a rural emergency and family physician based in Grand Falls, Windsor, Newfoundland and Labrador. David completed his residency training in both rural family medicine and urban enhanced skills in emergency medicine settings, and has been practicing since 2019. David has worked throughout Newfoundland from a 3-bed department to the Provincial Trauma Centre. David is chair of the Research Committee for the Society of Rural Physicians of Canada and a member of the CAEP Rural, Remote and Small Urban Section Committee. David's research interests include simulation and rural health access. Dr. Greg Costello is a graduate of the UBC Southern Medical Program in Kelowna, BC, and completed his family medicine residency training in 2018 in Chilliwack, BC. He currently has a half-time rural remote general practice in Bella Bella, BC, which includes longitudinal outpatient care, emergency department coverage, hospital and long-term care coverage. The rest of the time he spends with his wife in Kelowna and working as a casual hospitalist at the Kelowna General Hospital, in addition to providing episodic virtual care and clinical skills teaching within the Southern Medical Program. Dr. Stephanie McClellan practices emergency and family medicine in Invermere, BC. She graduated from the University of Alberta in 2002. She has worked in many rural and low-resource settings, including stints in Nunavut and missions with Médecins Sans Frontières in South Sudan and Iraq. She developed a strong interest in point-of-care ultrasound through her work in those settings and completed a POCUS fellowship at St. Paul's Hospital in Vancouver in 2020. Lastly, Dr. Taff Mix is an emergency physician at the Brandon Regional Health Centre in Brandon, Manitoba. He is the Brandon site lead for the University of Manitoba's CCF EM residency program and POCUS lead for the Department of Family Medicine. He has taught numerous POCUS courses, and his publications focus on expanding POCUS use in family medicine and rural areas. I would like to take a moment also to acknowledge that I am speaking to you from the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. The panel and myself, we respect the treaties that were made on these territories that we inhabit. We acknowledge the harms and mistakes of the past, and we are dedicated to moving forward in partnership with all Indigenous communities in a spirit of reconciliation and collaboration. Each presentation will be about 15 minutes long, followed by 10 to 15 minutes of a live Q&A at the very end of this presentation. If you have questions for one of our presenters, please use the chat function and we'll try to get through as many as possible. CAEP's Scientific Planning Committee has reviewed each participant's conflict of interest submissions, and none of our speakers have potential conflicts of interest, and no external supports have been received for this presentation. Map and graphics are just to demonstrate that this panel literally has been from coast to coast of the country. The learning objectives for this presentation are to demonstrate the clinical utility of POCUS in resource-limited settings, provide a brief overview of the state of technology and evidence in the field, and direct participants on where they can go to learn more about POCUS and obtain appropriate training. I'd like to start with a poll question for the participants. If you could please answer, where do you practice? Rural, remote, or community urban? Thank you for answering that question, participants. 66% of those of you that have tuned in are working in a community or urban environment, and 33% are practicing in a rural or remote environment. So we'll dabble in a bit of the evidence for the POCUS nerds out there. This will be preaching to the choir, so bear with us. Clinical utility of POCUS in resource-limited settings. POCUS enables rapid diagnostic imaging to be performed at the patient's bedside, and POCUS reduces time to diagnosis. The data also supports that POCUS can minimize the need for patient transfers, and POCUS can reduce healthcare costs, both of which prevent the disruption to patients' lives. The technology for POCUS has evolved quite significantly. The traditional, historic, large devices that were wheeled out and were consumed with buttons that most of us would be intimidated by has transformed itself into pocket-sized, portable, battery-operated, wirelessly connected devices that are readily deployable in a clinical environment without much burden. The slide here just shows some of the many various types of small portable technologies that are currently available. POCUS is a unique and very important role in the resource-limited environments. In rural and low resource settings, POCUS has demonstrated an ability to change differential diagnosis and management. And in low resource settings, this has had profound impacts on emergency obstetrical ultrasound, in particular ectopic pregnancies, the trauma fast scan for free fluid in the abdomen, cardiac ultrasound, and surgical emergencies like ruptured AAAs. In one study, a protocol for bedside ultrasound by ER providers and the evaluation of patients with first trimester bleeding found a decrease in delay to diagnosis and decreased the rate of missed ruptured ectopic pregnancies from 50 to 9%. An RCT has demonstrated that the FAST scan decreases the time in operative intervention when compared to standard clinical practice. And patients that received a FAST had a 64% decrease in time to definitive operative intervention, and therefore also a decreased complication rate and shorter hospital length of stay. For Canadian rural and remote context, patient transportation, especially emergency medevacs or air evacuations, is an essential but very costly component of our healthcare system. And that distance for rural and remote settings from services provides access barriers that can have significant implications on time to delay, especially when combating issues like weather. By relocating or expanding services in our rural and remote settings, we can help mitigate some of these challenges. For context in terms of cost, transfer from Canadian rural emergency departments for diagnostic imaging, depending on which studies you look at, can account for 15 to 30% of transfers to urban centers. So rural point of care ultrasound has implications not just in the rural environment, but implications in terms of patient flow through urban environments and urban ER departments. Some references for those studies that were cited. Now that everyone's been convinced about the utility and practicality of emergency point of care ultrasound in rural and remote clinical environments, let's get started with our first case presentation. I'm going to hand it over to Dr. David Bradbury Squires.
Thank you, Dr. Andani. So my name is David Bradbury Squires, and I'm going to talk to you about our first case this evening, which is flank pain. So I'm coming at you from the east coast of Canada, rural Newfoundland and Labrador. This is the kind of standard map of Newfoundland and Labrador on Canada. On Canada's map, however, this is what Newfoundland and Labrador actually looks like when you're just above it in a satellite. So what you have here is the Parsons projection map. I'm located just southeast of Moose, north of our provincial plant, which is the Pitcher plant here in Grand Falls, Windsor, which you can see denoted by the arrow and a picture of our old mill upon which the town was built. So How we typically do this is we do shifts in Grand Falls, Windsor. So we do 2-day shifts followed by 2 night shifts. It's my second night shift, so I'm almost done my stint. It's around 3 o'clock in the morning, and I see someone checking with flank pain. I've just settled things down. I've just started to go through all my charts, and I'm hoping to even get a little bit of rest, which will be awesome on my second night shift. So it's a 23-year-old female. She's coming in with left-sided flank pain. It's been going on about 3 days. She tells me that she's had some mild increased urinary frequency. However, she's actually been drinking a lot more water recently, as she was worried she had a UTI and a friend told her to do so. She also describes some suprapubic abdominal discomfort and nausea. Review of systems show that there was no fever, there was no chills, rigors, vomiting, or hematuria. She's currently on her menstrual period. She has no past medical history that is relevant, and she is on no medications and has no allergies. On initial examination, she really looked quite well. She was in no acute distress. Her vital signs were stable. She was afebrile. There was some mild suprapubic abdominal tenderness to deep palpation, and examination of her left CVA was really quite equivocal. It wasn't the classic percussion tenderness to her left CVA, and it was more MSK-like in that it was really more palpation that was tender. Her urinalysis was essentially unhelpful. She had 100 leukocytes, which is maybe confounded by the few epithelial cells. She had 100 red blood cells along with negative nitrites and a negative pregnancy test. So keep in mind you're in my rural emergency department in central Newfoundland. What would your next step be without POCUS at 3 o'clock in the morning? A, would you do some blood work, maybe do a CBC, lights, BUA, and creatinine, although that may not get you where you need to go. Would you just diagnose her with mild pyelonephritis or complicated UTI, treat her with some oral antibiotics, give her some good return to ED instructions, and pray that she can access a family doctor to get some community follow-up, as I'm sure it's quite difficult across the country because it is here. Would you consider arranging a CTKUB? We're going to wake up our friendly neighborhood radiologist, and of course they're going to love that. We're also going to have to transfer to an alternative site around an hour away, as our CT scanner is down, and of course it is. This is always the conundrum. Or would you do some combination of A, B, and C? All right, great. So it seems like most people are kind of do some combination of A, B, and C, and it seems like a reasonable choice. You would probably start with some blood work, maybe consider the diagnosis of mild pyelo or a complicated UTI, and then depending on your clinical impression, can carry on with a CT KUB or CT renal protocol, whatever you go by. So this was my wake-up call that night. So as a rule, when I started to learn ultrasound, for every flank pain that I saw, I would always bring my ultrasound in and get in the habit of doing a scan for a AAA, as well as a scan of the symptomatic flank looking for hydronephrosis. So what you're seeing here is you're actually seeing what's called the bear paw sign. The bear paw sign is indicative of severe hydronephrosis. So what you'll notice is that you get dilatation of the renal pelvis along with the major and minor calyces, and pretty much obliteration of the renal pyramids there. So scanning for hydronephrosis is actually quite simple, and it's really similar to the FAST scan, which the majority of us that practice with ultrasound are familiar with. So your external landmarks are the xiphoid process in the mid-axillary line. In the longitudinal plane, what you're going to want to do is go more towards the feet, where you can center the kidney in the middle of your screen. You may need to tilt the probe left or right, depending on which side you're on, in order to get around the ribs. And you want to ensure that you sweep the kidney from anterior to posterior. You're going to want to then go over to the transverse view, and then you're going to want to complete a full sweep of the kidney from that view as well. So what you'll see here is a diagram of hydronephrosis. So this is important because we as emergency physicians are really best at determining a dichotomy between normal and then moderate or severe. We trip up a little bit as we go through the grades, and I'll get into that in a little bit. So on the left here, we see a normal kidney. As you progress, you start to see dilatation of the renal pelvis, followed by dilatation of the calyces, and then obliteration of the renal pyramids in severe. And of course, you can get a hydroureter with this at any point as well. So this is a normal scan for hydronephrosis. So what you're seeing here is very similar to our fast view. You notice that the renal pelvis does not appear to be dilated. And when someone was explaining this to me, they said, they kind of explained it that, hydronephrosis is fluid where there shouldn't be fluid. So there's a lot of fluid in the renal pelvis. So fluid on ultrasound, of course, is black. So there will be black fluid where there should not, and that will be within the white of the renal pelvis. So moving on to more of the mild and moderate hydronephrosis examples. So here on the left side of the screen, you can see the mild hydro. So you're starting to see that black fluid in the white where it should not be. And then as we move towards the more moderate hydronephrosis, you're seeing further dilatation of the renal calyces and the renal pelvis there. And you can see that sometimes maybe, this is a really good image on the left of mild hydro, but, depending on the patient's body habitus or other technical difficulties with the scan, that may be difficult to distinguish from a normal kidney. So here we go. Here's our good old Beer-Pass sign again. So again, this is indicative of severe hydronephrosis. And although this wasn't the exact patient scan, her scan did look a lot like this. So as we integrated the hydronephrosis scan into our clinical picture, we start to expect an obstructive uropathy, which was really, really quite surprising. So although we do have a huge prevalence of renal colic and nephrolithiasis in Newfoundland and Labrador, this was a 23-year-old female. She had no previous history and really no risk factors from what I could tell. We did some blood work on her, and we subsequently found that she had an AKI. So her creatinine went from a baseline of approximately 70 to around 130. As this was the middle of the night, we wanted to avoid a media transfer. So we held her overnight. We treated her with some IV fluids, some analgesics, covered her with some empiric antibiotics, and transferred her to another center for a CT scan in the morning. That CT scan actually showed a huge stone, 11 millimeters, and this was causing moderate to severe obstructive uropathy. We then consulted urology directly for definitive management of that stone, and I was feeling pretty SMRT. So although the examples with and without POCUS is maybe not as clear cut as what Dr. Hibbert is here suggesting, that hyperbole is useful to demonstrate the utility of POCUS in this scenario. So without POCUS, I would have maybe diagnosed this lady with cystitis plus or minus either MSK pain or pyelonephritis. I likely would have discharged her on some oral antibiotics with some return instructions, and she would have left the department. However, with POCUS, within 5 minutes of seeing that triage complaint, I was able to identify an urgent condition, and that immediately changed my management. This allowed me to appropriately image the patient without the indiscriminate use of ionizing radiation, especially important in this young female. And I was able to get this patient to definitive care, i.e. urology, much earlier than without POCUS. So the evidence for using POCUS as a first line versus a CT-KUB in anyone that you're suspecting renal colic. So POCUS does reduce radiation exposure, as discussed, and there's no difference in complication rates, serious adverse events, or repeat emergency department visits. POCUS also does reduce the ED length of stay and medical costs. As I mentioned, I was able to identify an urgent cause within 5 minutes of seeing this patient's complaint. One of the caveats of POCUS, though, is that we really need to be mindful of what we're calling hydronephrosis. So we're really better off when we use a dichotomous view of this. So when we consider none or mild on one end of the spectrum and moderate to severe on the other end of the spectrum. And this is really important because moderate to severe hydronephrosis is very, very specific for a symptomatic renal stone at around 94%. So these are my references. Thank you all for your time and answering our poll. So I'm going to push it to my colleague way, way over on the West Coast, Dr. Greg Costello in Bella Bella, BC.
Hello. Can you guys hear me okay? Rafiq, you there? Oh, excellent. So I'm way on the other side of the country here, sitting in health sec territory in Bella Bella. I am on sort of sketchy internet, so if I start to break up, I'm gonna have to ask somebody to tell me. Next slide, please. So we do 24-hour call shifts here in Bella Bella, and one very rainy evening, it's not nearly as pretty as that when it's raining, but it is fairly pretty, as you saw from the picture at the beginning. But it was pouring rain, and at 8:30 in the evening, next slide, please. A 75-year-old elder comes in, we haven't seen him in a long time. He's been a heavy smoker, but no other known real medical problems. But comes in with a several-week history of worsening fatigue. It's everyone's favorite chief complaint. It just gets you all excited when that walks in. He's a very challenging historian. He says maybe he's got some mild shortness of breath. Maybe this is getting worse, not really sure. The main reason he came in now is because now he's having some problems sleeping. So he's really tired and he can't sleep. So that's bothersome to him. Specifically, he doesn't have any chest pain. He doesn't have any leg swelling, no GI upset, no cough, no sputum, no night sweats, nothing else. He does have anorexia and weight loss over the last few weeks. Next slide, please. On physical examination, his vitals are normal. He appears cachexic and weak. He's using a cane to sort of get around because he just feels like he's going to fall over. He's decreased energy to his lungs, so you can't really tell if there's any crackles or wheezes because he's just not moving very much air at all, consistent with his history of smoking. He's got a normal JVP, no limb swelling. He doesn't look fluid overloaded at all. And when you look at his family medicine record, he was a previously robust guy, last seen 6 months ago for a cold, essentially, COVID negative, of course, but nothing really exciting. Next slide, please. So with this guy coming into your emerge, just with that story, with that vague information. What's your more likely diagnosis? Is it cancer, cognitive decline, COPD, or is it something else? And list what you think it might be in the comments for me, just in the next 30 seconds here or so. So those who have selected something else, please write it in the comments because we want to hear what you think.
We're seeing missed MI, cardiac, pneumonia, pyogenic pneumonia, CHF.
Okay.
As the other.
All right. I'm pretty happy with that response rate if we want to move along because I'm aware of the time here.
Yeah.
So yeah, I mean, like I just throw this together. So the differential list here is ridiculously broad, and you guys mentioned cardiac disease, substance misuse, environmental poisoning, definitely an issue in this community. Carbon monoxide, depending on the time of year. Inflammatory disease is ridiculously common here as well. So it's any and all of these are definitely on the table. Next slide, please. So without POCUS, how would you approach this patient? I'm not going to wait for folks to respond in the comments. We're just going to say, I would, consider any one of these, or any of these, and maybe all of them together, reasonable to consider in this gentleman, because really the stories and the physical exam aren't giving you very much. Next slide, please. However, as much as I would love to get a chest abdo-pelvis CT with contrast, I don't have that in Bella Bella, nor do I have formal ultrasound. I usually have an ECG in labs, but sometimes not so much. And even if I do have them after 8 p.m., this is definitely going to require a call out, and it's going to maybe take a couple of hours to get everything back. It's also not uncommon for our machines to break down, labs to be sent out, and that's going to delay things even further. So, we're quite, as much as we would like to get the advanced editing, get all these things, it can be quite some time and be a process to sort this out. Next slide, please. However, with that handy dandy point of care ultrasound machine, you can do a lot more in quite a short amount of time. So you can look at his lungs, you can look at his heart, you can look at his abdomen. You can start to rule in or rule out some of these issues. Specifically, you can be looking for CHF versus COPD. You can really, even while waiting for a chest X-ray, you can start to make some of those differentiations. You can look at his cardiac function. You can rule out a pericardial effusion. You can assess for ascites, considering maybe concerns for liver disease. And this can all be done really quickly with the appropriate training and practice. Next slide, please. So when I grab the ultrasound machine, I throw it on and I look at his lungs. I don't see any evidence of CHF. pleural effusions, or any ascites. However, when I throw the ultrasound on his heart, next slide, please, I see that his heart is not beating normally. So I don't know if the GIFs are playing slowly for you, but on the left-hand side, you can, so on screen right of that image, you're looking at the left ventricle, and you can see just grossly that black spot going away, and that's the left ventricle squeezing appropriately. On the right-hand image on screen right, you can notice that the left ventricle is not squeezing hardly at all. And the flappy thing, that's the scientific term, in the middle is the mitral valve, and the leaflet of the mitral valve that's of note there is not moving either in that right image. And that's the actual patient. With permission, I've got these, I captured these images. This represents an ejection fraction of less than 30%. Next slide. And then when you turn the probe around and you look at a different axis, so now we're looking down the barrel of the heart. Again, on the left-hand side, you can see, normal contraction of the entire left ventricular wall, like the donut closing in around the middle of the black fluid, which is the blood coming through the heart. And then on the right, you can see that's just a big old floppy heart that's not moving very much at all. And again, that donut is not contracting around the black fluid, which is the blood sitting in the heart. Next slide, please. So I'm looking at that ultrasound. I'm quite concerned about a cardiac cause of this gentleman's symptoms. I get 2 hours later, I get all of his the things that I can order back. He's got a very elevated BNP with no evidence of fluid overload. Abnormal ECG, he's got a new right bundle batch block and a left axis deviation. He's got an enlarged heart, and everything else is normal. Next slide, please. So I admitted him. I discussed him with internal medicine the next morning. It was a pretty quick acceptance down to Vancouver, which is a 2-ish hour flight away from here. And they quickly agreed to accept him for this new cardiomyopathy with cardiology to be discussed to see him when he gets there. Final diagnosis is non-ischemic cardiomyopathy. EF of 10 to 20% is the official reading when they check my work. Next slide. So basically, this was a gentleman with an incredibly large differential diagnosis coming in, delayed access to labs, no advanced imaging, and within 15 minutes, I was able to have a really good idea of what was going on with him, and be able to advocate with the site down in Vancouver to say, hey, we've got somebody who's got legitimate findings that line up with a cardiac issue. That's new, and it streamlined everything for me in every sense of the word. And again, all within 15 minutes of him walking within the emerge, was I able to get that information. Next slide. Those are my references to, again, just general excellent articles on using ultrasound in these settings. And next slide. And I'm going to pass it on to the next person. And Stephanie, you're on.
Thank you. Next slide, please. So I'm coming to you from Invermere, which is in the rural interior of British Columbia. We're kind of at the eastern edge of British Columbia. And just for the setting, we're an 8-bed hospital. We don't have an OR. We don't have a CT scanner. It's about 130 kilometers to the nearest OR or a CT scanner, as well as formal ultrasound. And our nearest tertiary care center is in Kelowna, which is 460 kilometers away. And just for interest, we have 6 units of blood in our hospital. Next slide. So this was a case I saw a couple months ago in the ER, and it was a 25-year-old woman. She actually came in around 2 or 3 in the afternoon. So I had lab in-house, although after hours, it's much like everybody else's ER, where we'd have to call somebody in a rural setting. But so yeah, it was afternoon. This 25-year-old woman came in complaining of abdominal pain. And she had done a home pregnancy test, which was positive, and her last menstrual period was about 5 weeks ago. Her vitals actually looked pretty good for a young, healthy woman. Her blood pressure was 98/60, her heart rate was 60, and the rest of her looked pretty good. Next slide. And so when I went to examine her, she looked like she was in a bit of pain, but not in acute distress. Her color looked good. Her belly was pretty soft, no real focal tenderness. Definitely no signs of peritonitis. And full disclosure, I did actually not do the pelvic exam until after I'd done the ultrasound, because as in most places, it's actually easier to do the ultrasound than to do the pelvic exam, just logistically. But when I did do the pelvic exam afterwards, there was no blood, a little bit of tenderness again, but not extremely tender. Next slide. So with that information, and not having had access to POCUS at this point, what would you do next? So order some labs, your quantitative HCG, just call the nearest referral hospital and send her down for an ultrasound, call gynae on call for advice, or do some combination of A, B, and C. And maybe while you're thinking about your polling question, I'll tell you some interesting fact about Invermere, BC. We actually hold the Guinness Book record for the longest skateway in the world. We have a lake that freezes every winter, and our local ski club plows a 30-kilometer loop for skating on the lake, which is really awesome. So if you come to Invermere in the winter, you'll have to bring your skates.
So we're getting some votes in already for transfer for formal study. And 30% went with A, CBC lights, type and screen, and quantitative. 10% went referral. 0 said call gynae on call, and 60% said some combination of A, B, and C.
Okay, great. So yeah, next slide. So just, and maybe the question isn't totally fair because you don't know where I work and how easy or difficult it is to get these results. But so typically a quantitative HCG actually gets sent to the referral hospital, and then we get a result back about 6 hours later. So it's not immediately useful. The diagnostic ultrasound, so it's an 1.5-hour drive if you go by private car. If you go by ambulance, it's sometimes even slower because we don't have a lot of ambulance resources. And then typically when they get down there, they wait in the ER for a couple of hours to get squeezed in between scheduled patients. And so it could be another 2 to 3 hour wait. And then gynae on call, which all of you were clever enough not to pick, because invariably they're probably in the OR when you try to call them, and they'll call you back 2 hours later, and it's not helpful in the immediate setting either. And then when they call you back, they'll probably tell you to send the patient for an ultrasound anyways. So anyway, but we have POCUS. So next slide. And as I already alluded to, I actually grabbed the ultrasound when I went to see the patient. So I had it immediately available. And I think you'll be able to appreciate, and I don't know, Rafiq, if you can, maybe just point to the fluid collection there in Morrison's pouch in her right upper quadrant. And then next slide, it was actually more impressive in her left upper quadrant. You can actually just see her spleen floating around in free fluid in her belly. It was actually quite impressive. I did look at her pelvis as well, and it was actually not a very remarkable scan, so I don't have the image saved here, but there was just a little bit of free fluid in her pelvis, and obviously no visible intrauterine pregnancy. So next slide. So clearly, abdominal pain, we have a positive pregnancy test and a positive FAST, so that all adds up to a ruptured ectopic pregnancy. Next slide. But what really struck me in this case was that if you just saw the patient, you didn't have ultrasound, and you just saw her, her vitals were actually pretty good. Her blood pressure is 98/60. That's my blood pressure on a good day. That's not uncommon for a young, healthy woman. Her heart rate was 60. So there was no real indication that the patient was in shock. So, your exam was essentially unremarkable. So, being able to visualize that free fluid in her pelvis really changed the management quite drastically. So next slide. So really, you had your diagnosis very quickly. And I think where point of care ultrasound is very useful in the rural setting is that sense of clarity. It makes your transfers a lot easier when you have an understanding of what's going on with the patient. And also in her case, if I didn't know that she was already ruptured, I might have sent her to the receiving center by private car, because our ambulance resources are always so stretched that it's always faster to go there by private car. But knowing that she had a ruptured ectopic, clearly we had to advocate for her to be a red ambulance transfer. So that definitely made our transfer decision much easier. Next slide. And that's all for me. I think the one teaching point I would like to point out is that you don't have to be very good at doing first trimester ultrasound in this situation. Just about every ER doctor in the country knows how to do a fast scan, and that would be where I would recommend starting in these cases, because if you see free fluid and a positive pregnancy test, you're done. So next up is Dr. Taft Mix from Brandon, Manitoba.
Hi guys, thank you. So yeah, we've gone from coast to coast. We've gone from Newfoundland to BC, and here we are in the center of Canada and Manitoba. So I want to tell you about a case of testicular pain that came into my emergency department. So here we are in Brandon, Manitoba. We're just 2.5 hours west of Winnipeg. And so this case happened on an evening shift in my emergency department here in Brandon at around 7 p.m. And this would be after hours for us for radiology. We would have to call in radiology if we want to get a CT, MRI, or ultrasound. So this 13-year-old male came in complaining of acute onset left-sided testicular pain. The onset was 3 p.m. that day. Again, we're now 7 p.m., 4 hours ago. So that's going to be really important here. And was complaining of a severe dull ache. He complained of it kind of on and off the past few months. Each time it would resolve after a few minutes. And then talking about other things, no dysuria, no urinary symptoms, hematuria, fever, wasn't vomiting, and no history of any trauma. So examining the testicles here, the left testicle was obviously high riding. It was swollen, diffusely tender. The testicle itself was really firm. Interestingly, no horizontal lie in this case. And as far as cremasteric reflex goes in Prensign, I don't do them anymore. I don't find they're all that helpful. I think the evidence would also point towards that. I find I have better tests with point of care ultrasound, and I can get a urinalysis pretty easily. Completing the rest of the exam there, the right testicle was normal. GU exam otherwise was normal. And as you can see there, the urinalysis was entirely negative. So our differential diagnosis, I think all of us here, I'm speaking to mainly emergency physicians. Testicular torsion, number one. Epididymoarchitis certainly is there, but didn't really have symptoms in keeping with that. No evidence of hernia, and a few other diagnoses there you can consider, but again, no evidence of any trauma or no history of trauma. So we have this article here from the Canadian Journal of Emergency Medicine. And it was written by the first author there, Dr. Rosenberg, who actually worked with as a medical student. So if you're watching this, I just want to say hello. And so in all the literature, we have this kind of 6-hour cutoff for restoring blood flow. And we really want to meet that as best as we can. So I kind of found another paper here doing a literature review for this presentation, showing that the door detorsion time determines testicular survival, which is pretty intuitive. When we restore blood flow earlier, the more likely we are to have better outcomes. So again, it's pretty important that we do this as fast as possible. So in my setting, if I were to call in radiology in this case to do a diagnostic ultrasound, again, we're at 4-hour mark. That would have added about another 45 minutes to 1 hour to get the results of that. If I immediately called to transport to Winnipeg for this patient to be seen by pediatric urology, they would have arrived at about the 6.5-hour mark. So again, over that 6-hour time period, we want to get this done. And if I had done both, if I had ordered an ultrasound, got those results, saying testicular torsion, then arranged for transport, by the time the kid arrives there to be seen by pediatric urology, we're at 7.5 to 8 hours after onset of pain. So the question is, what would you do in my situation? If it was you, would you be calling to request an emergent diagnostic ultrasound? Would you be organizing emergent transport right away to see pediatric urology in Winnipeg? Or would you do both? So while we're waiting for these answers here, I'll tell you a bit about Brandon, Manitoba. I didn't realize till I got here, I'm originally from just north of Toronto. I've been here for 4.5 years now. I did my residency here. We actually have skiing in Western Manitoba. I didn't know that till I got here. It's 2 hours north of Brandon.
Lots of votes coming in, Taft. It seems like many people have strong opinions on torsion management. And we do have a question right now that while we're waiting for those votes is how cold is it in Brandon right now?
It's not that bad. It gets down to -40, -50, the wind chill sometimes. It can be pretty cold, but if you got a nice jacket, it's okay.
So 46% said B, organized transport, and 53% said A and B.
Awesome. All right. So it's a bit of a trick question because what I did in this scenario is I have point of care ultrasound. We have a beautiful Sonosite export machine in our department. So if many of you don't have exposure to testicular ultrasound, the way this is generally done is using a linear probe, which you can see there in the top left. And you can interrogate each testicle individually, starting with the asymptomatic, the normal testicle, to get all your settings done. And so you can start with the sagittal or longitudinal view of the testicle, sliding side to side to look at it, and you'll get the ultrasound image on the top left. Switching then to a transverse view, and you'll get the image on the right. That little circle there, I didn't mention this, but is the probe marker, so kind of up towards the patient's, I suppose, well, superior, and then to patient right. And once you get those, you can kind of bring the testicles together, examining both of them at the same time, and you can throw a box over for color Doppler or power Doppler to see if there's any blood flow. Spectral Doppler is a bit more advanced if you actually want to assess the blood flow if it's arterial or venous, which I'm not going to really go into in this presentation, but I've got some resources for you if you want to learn more about this. So I had first learned to do this at the 83 course, which I took during my family medicine training. I did my family medicine in rural Newfoundland, and I had gotten an introduction to ultrasound my first year. Second year, I loved ultrasound. I took all the courses. And you can also read about it in this ultrasound on the right there that is available for free. It also links to their podcast, which has a really good explanation on how to do this. And I guess the question is, should we be doing this? Well, we have this paper here from 2001. They looked at numerous diagnoses related to testicles and found that emergency physicians are pretty accurate in the diagnosis. Important to note that in this paper, they only looked at 3 actual cases of testicular torsion, so not that many. And the next paper we have here is more comprehensive. So Rafik, I'll just get you to go ahead to the next one. So this one here, they looked at quite a few more patients. And so the accuracy of point of care ultrasound by pediatric emergency physicians for testicular torsion, published in Pediatric Urology in 2019. So pretty good numbers there for sensitivity, specificity, positive and negative predictive values. And they felt that this was, pediatric emergency physicians were pretty good in diagnosing this, and maybe we can add it to our toolbox. So in this case here, starting with the normal testicle, the right testicle, so examining it as I explained, then throwing on color Doppler, you can see there we're picking up pretty good blood flow with these settings. The argument could be made of using power Doppler instead, which is more sensitive for low flow, but I was able to use color Doppler in this case. And if you're not used to this, the red indicates flow towards the probe. The blue is flow away from the probe. So it doesn't tell you if it's arterial or venous. Some people have this misconception that red is arterial, blue is venous. That's not true at all. So then moving on to the symptomatic testicle in this case, throwing the color Doppler on there, the exact same settings, we see a complete absence of blood flow. You can also see there's fluid around the testicle, so there's a hydrocele with this as well. And then moving more towards the superior end of the testicle, we see what's called a whirlpool sign and a twisted spermatic cord with all this fluid around it as well. And so the whirlpool sign has the highest specificity and sensitivity for a diagnosis of torsion. There is an incidental finding of a little epididymal cyst there, but that doesn't really have anything to do with this. So I was able to confidently diagnose testicular torsion at the bedside at initial patient contact using point of care ultrasound. We then brought them over to our trauma bay, proceeded with procedural sedation using ketamine. And in this case, what I did, so as the textbook explains, using the open book technique, I was able to turn it 180 degrees and was able to feel that the spermatic cord, that knot, was now gone. The other case I've done exactly like this, that was done, I did it 4:30 in the morning a few years ago. The open book technique on the same left testicle actually made it worse. The knot I could feel get worse. I had to do 540 degrees the other direction for it to go away. But in this case, so let's say you can't feel the knot anymore, but you think maybe there's blood flow. Well, the textbook always says the patient's pain should be gone. But what do? You can't really speak to them right now. They're still sedated. So, do you wait? Well, no, you just throw the ultrasound back on and we can see pretty obviously here blood flow has been restored. So it's pretty awesome. So in summary, I was able to confidently diagnose testicular torsion at the bedside immediately at the time of patient contact. I was able to confirm blood flow after detorting it using POCUS while the patient was sedated. And I was able to get within that 6-hour window, whereas calling a radiology, transporting them, it would have delayed it beyond that with possibly a worse outcome for the patient. So yeah, thank you.
All right. So thank you to our presenters. Seems like we've got about 15-ish minutes left for questions. So we'll open that up to people in the chat. I see one already. So did the patient go to Winnipeg for surgery, and was urology cool? I think that's for you, Taft.
Yeah, urology was cool. The 2 cases I've done, in that case, yeah, urology wanted to see them that evening, so we did arrange transport afterwards. The previous case I had a few years ago, surprisingly, urology just wanted to see them a few days later. So I thought that was kind of interesting.
Access the consult, we'll see him as an outpatient in 4 to 6 weeks. I have a question for the panel, and you guys can answer in no particular order, but what barriers have you experienced in trying to incorporate POCUS into your rural practice, and how did you overcome them?
I'll let others speak first, and then I'll kind of talk about a paper we published in the past about this.
I'll bite. Oh, sorry. Go ahead.
Sure. I'll talk about my experience, and I'd like to give a shout out to the BC POCUS program. They do these really awesome courses called the house courses, which will come to your community and focus their teaching to your community as well. And then I got in touch with the BC POCUS program at St. Paul's Hospital, and they do these really great ultrasound immersion experiences. And it's a bit of like choose your own adventure, where you go and you can go for a week or 2 weeks and you're one-on-one just scanning patients in their department and having somebody look over your shoulder and just help build that confidence that you know what you're looking at and that your technique's good. And then from there, I ended up doing the 9-month fellowship at St. Paul's. But the short program they have is really excellent. And something like that, where you just have somebody coaching you, I think is really great.
And just to riff off of that, so in BC, we're lucky to have those programs, the house course and the fellowship out of St. Paul's. Access to machines and expertise is a big barrier when you're working in small sites. If you've got somebody local who can champion point of care ultrasound, it's widespread, and more people are getting interested in it. But in smaller sites, you still may have nobody who knows how to use the machine that was bought by the health authority a while ago and sitting in the corner. Or you may have a bunch of people who are really interested in it, but may not have actually access to a good machine. In BC, we had a program called the InPOCUS program, which spread ultrasounds around the province, but there are still many different parts of BC which don't have access to it, and that's probably the biggest barrier, either expertise or equipment.
I think another big barrier.
Oh, yeah, sorry.
Oh, go ahead, Taft.
So I'm just going to mention a paper we wrote, actually published in CGEM back in 2016, titled "Barriers to Point of Care Ultrasound Use in Rural Emergency Departments." So we have a few barriers there: lack of equipment, lack of training, lack of funding, inability to maintain skills, and lack of quality assurance. And we wrote about how to address those for those of you working in rural emergency departments. So please check out that paper. One of the things I always encourage people, if after you take your introductory course and you learn these skills, what I find is people then go to a community site or rural site where they don't have that POCUS lead to necessarily supervise them or teach them. But the way I had to learn these skills, gallbladder, cardiac skills, was at every opportunity you have, use the ultrasound machine, take a scan, record the video, record the images, and then when you order that diagnostic ultrasound, follow up on it, follow up on the results, speak to the radiologist, and get the feedback that way. And I think little by little, as you do these cases, you'll learn over time.
Yeah, so kind of echoing what Taff was saying there. So the biggest barrier I think is learning. So I did my residency rural, similar to some of you folks as well. And as a resident, it was really difficult not only to get access to someone who used POCUS comprehensively as part of their practice, but then to also get scans signed off and to get exposure to other scans that are not part of the standard introductory POCUS course, such as the more advanced cardiac scans, the hydronephrosis, that sort of stuff. So from a resident level in particular, one of the big barriers is actually just getting someone who has POCUS skills and are able to teach you that.
Greg?
I just want to make one final point, just echoing everything that was said, but adding on the fact that I think in pretty much every province in BC, you can't really bill separately for point of care ultrasound. And I think that even though there is evidence that it improves quality of care, that it can, we've given you cases that it can make a huge difference. It can slow you down at first, for sure, and it can decrease your overall volume a little bit, or potentially a lot early on. But I think there's an argument to be had about the utility of point of care ultrasound and how much of an impact that can have on your practice and for your patients. And that's a big discussion around billing and fee for service versus salary versus this or that. But ultimately we have to acknowledge that there is pressure to see people quickly, and this can slow you down a little bit, but over time you get faster and you get better at doing these scans, and it can actually speed up your assessment, as we've seen in a number of cases here.
Thanks, Greg. There's a question from one of the participants. Caleb said, has anyone had success in gaining access to have your scans shared to PACS? Seems a selective allowance for this would enable radiology/surgery to see the scans themselves prior to shipping.
I can speak to that if you'd like, Rafi.
Sure.
So I personally haven't seen it. It's very common apparently in the States, and someone else can maybe correct me on that, but it is essentially a quality measure where point of care ultrasound is uploaded to PACS and sort of overread by radiology. That gets into a bigger question of whether or not point of care ultrasound is a radiological test, or if it's an extension of the physical exam. And whether these should be saved or for later scrutiny or not, or signed up. I haven't seen it, but it is coming. I think in BC especially, there's talks of it coming, and where it will be the default, where your scan, it will be expected that it be uploaded and saved to PACS and sent to someone else.
One other option that I'd like to point out is that a lot of the handheld ultrasounds have the ability to send live video as you're scanning. So some of them, the Lumify, I think you need to have a subscription to their program to do that. I think the Clarius, you just send somebody a link and they can watch you on their phone as you're doing the scan. So that's actually really nice to share with consultants if you have a handheld ultrasound.
And even lower fi than that, with patients' permission, of course. A couple times I've actually just texted the picture or a video to a consultant, or whether that's at my site or remotely. And patients are pretty accepting and appreciative of that when you say that, hey, I can get a specialist to have a look at this, and maybe we can get you a little bit more help a little bit sooner. They're pretty cool with that in my experience.
The future of image sharing I think there's just a recent article from one of our CAEP Ultrasound Committee members about imaging being the new wave of sharing patient information. But I would love to see a Grand Rounds debate about whether POCUS is an extension of the physical exam or a bedside test, because I think that would be a spirited debate. No one questions me about my breath sounds or if I heard a murmur, but all of a sudden when I'm telling this free fluid, there's suddenly some doubt. These have been some great cases. We've mostly come to the end of our allotted time, so I just want to take this opportunity to thank our fantastic speakers for these presentations, and a thank you to our audience for your time and for your participation. Each of us hopes that this presentation has helped demonstrate the value and utility of point of care ultrasound. And if you are interested, I'm going to put a slide back up that shows some additional resources and links and organizations so you can access point of care resources. But thanks again, everyone.